Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Alnylam Pharmaceuticals, Inc.
This program is presented by Medscape Education Global.
Hello, everybody. My name is Prem Soman, and I'm a professor of medicine at the University of Pittsburgh and director of the Cardiac Amyloidosis Center at the University of Pittsburgh Medical Center. I'm very delighted and feel very privileged to be moderating this session by Medscape Global on updating our checklist for TTR cardiomyopathy monitoring. I will begin with a brief introduction and some updates on the current recommendations for cardiomyopathy monitoring. And I'm delighted that I'm accompanied by two internationally recognized experts in cardiac amyloidosis, Dr. Sheikh from the National Amyloidosis Center, who will be speaking on imaging in cardiac amyloidosis and taking us through some exciting new data, and Dr. Leray from France, who will be talking about some extra cardiac manifestations that are important to the patient's quality of life and approaches to monitor and treat autonomic and gastrointestinal symptoms. Now, it would not be an exaggeration to say that there has been a revolution, not just an evolution, in ATTR cardiomyopathy care. Not very long ago, we thought that this was a rare disease that required a cardiac biopsy for its diagnosis, and we did not have any therapies for it. Therefore, it was just a diagnostic curiosity. In less than 10 years, it has transformed into what we now know as a prevalent disease, which can be diagnosed non-invasively in the majority of patients, and now with not one, but multiple life-changing therapies. Yet, despite this dramatic transformation, many unanswered questions remain, importantly around disease monitoring. Now, there are some unique challenges with disease monitoring in cardiac amyloidosis. For example, it is a multifaceted disease with many extra cardiac manifestations. There is a frequent lack of concordance between symptoms, laboratory testing, and imaging. Importantly, there are many aspects of TTR pathobiology that remain uncertain. For example, we don't fully know what happens in the myocardium when we treat the disease. And there is, of course, a distinction that needs to be made between progressive amyloidosis, i.e. continued deposition and infiltration with amyloid, versus clinical patient deterioration. And these are not always the same. Now, in 2021, an expert panel came up with some disease monitoring recommendations. They recommended multi-domain monitoring, and the recommended domains were functional capacity, patient-reported symptoms, biomarkers, and imaging. And they emphasized that progression or regression should be assessed across multiple domains, and not just symptoms. And these were the 2021 recommendations. Now, soon afterwards, the expert committee realized that there is the need for an update. This was based on the emergence of very important new prognostic data, the fact that most patients are now diagnosed earlier in the course of the disease, and they felt that there was the need for a feasibility approach, or feasibility-based approach to monitoring, i.e., the algorithm should contain clinical parameters that are easy and straightforward to assess. So earlier this year, the expert panel came up with updated recommendations that I will go through in detail. Now, here are the multi-domain assessments that are recommended for the contemporary monitoring of cardiac amyloid, TTR amyloidosis patients. Now, two important points to remember. First is disease progression can be considered to occur when each of these thresholds are met, i.e., it's not enough to just have an increase in these parameters. These parameters need to meet the recommended thresholds, which I will go through. Secondly, a parameter should be evaluated every 12 months and compared to the parameters measured in the prior 12 months, not at the patient's baseline. And more frequent measuring of parameters is not recommended because multiple measurements can mislead assessments based on noise and maybe biological variability. So it's important that assessments are made just every 12 months. So let's look at the individual criteria. The first was related to heart failure-related hospitalizations. And this was very specifically defined as a greater than 24-hour inpatient stay or a less than 24-hour stay with the institution of the IV diuretic. So very specific criteria. The second clinical criteria was outpatient diuretic intensification, which was defined as institution of any new loop diuretic or a sustained increase in the dose of the diuretic for more than 30 days. This definition was what was adopted in the DELIVER trial of dapagliflozin. Now, those were the two criteria based on clinical assessment. The second category are biomarkers, and the first in these is NT-proBNP, and the criteria for progression was an increase of greater than 700 picograms per ml or a relative increase of greater than 30%. Now, please note the criteria with the "and" requirement, and this is to avoid overdiagnosis of deterioration based on biological variability. So the absolute criteria and the relative criteria both need to be met. It's important to note that the biomarkers should be measured during periods of clinical stability, or they should be based on at least two measurements 4 weeks apart. The second biomarker criteria was eGFR, and the criteria for disease progression was a relative decrease of greater than 20%. Now, here again, it's important to measure this during clinical stability, and this must be correlated clinically with other factors such as hypotension, dehydration, and new medication institution that could change the GFR without a true deterioration in the patient's clinical status. And the two other functional parameters are the 6-minute walk with a deterioration of more than 35 meters and a KCCQ quality of life assessment, again with specific criteria. So this is now the contemporary recommendation based on the 2026 guidelines. Now, there are some important considerations to note here. One is that all of these criteria measure disease progression as opposed to specific progression in amyloidosis itself. Notably, disease progression may also be due to worsening heart failure, arrhythmia, or aging. And because of this, disease progression should not necessarily lead to changing or stopping ATTR cardiomyopathy therapy. This is a very important caveat that should be taken into account. Now, the other point to consider is that imaging parameters were excluded. You know that there were imaging parameters included in the 2021 recommendations, which were excluded from the updated recommendations. The expert committee felt that these were not reliably included because of high interobserver variability and a difficulty in accurately interpreting the results, i.e., small changes over time. Now, as far as imaging is concerned, if we look at the bulk of the emerging data on serial imaging in amyloidosis, the unifying theme is that the observed changes are small changes in the measured parameters. They're measured in highly expert co-labs. They're often compared with an untreated or placebo group. So these small changes are easy to interpret when they're compared to an untreated or placebo group. But when these small changes occur in individual patients, they are more difficult to interpret. And importantly, there's a frequent lack of concordance between changes in these parameters and in the structure and function of the heart. So these are challenges that we face when we use imaging, serial imaging for follow-up in cardiac amyloidosis. Significant knowledge gaps still continue to remain. Extracardiac symptoms are important, as Dr. Leray will tell us, and they contribute significantly to morbidity in ATTR cardiomyopathy patients. These are not considered in monitoring. And as I mentioned earlier, there are no markers specifically of cardiac amyloidosis progression. So this is sort of a snapshot of the current recommendations for monitoring. I will now hand over to Dr. Sheikh, who will give us an overview of imaging, and Dr. Leray will follow up with autonomic neuropathy and gastrointestinal symptoms. Thank you.
Hello, I'm Owais. I'm one of the clinical fellows at the National Amyloid Centre in London, which is the tertiary referral centre for all amyloidosis patients in the UK. So I have extensive experience managing patients with ATTR-CM. So what I'd like to talk about today is why imaging is so important. So traditionally, we've relied on biomarkers such as BNP and troponin. They're useful, but fundamentally, they're late and indirect markers reflecting downstream consequences like wall stress and myocardial injury rather than the underlying disease itself. In contrast, imaging, in particular cardiac MRI, allows us to directly assess myocardial amyloid burden, giving us insights into the degree of amyloid infiltration within the myocardium. This has become particularly important in the current treatment era. With disease-modifying therapies, our goal is no longer just to diagnose, but to track disease progression and assessing whether treatment response evolves over time. In clinical practice, we rely on a multimodality imaging approach, with each technique providing complementary information. Echocardiography remains the first-line investigation. It's widely available and allows us to assess changes in cardiac structure and function. Bone scintigraphy, using tracers such as DPD or PYP, has become central to non-invasive diagnosis, allowing us to identify ATTR-CM with high specificity in the appropriate clinical context. PET-CT is an emerging modality with the potential to provide more sensitive and quantitative assessment of amyloid burden. Finally, cardiac MRI plays a key role in tissue characterization, with techniques such as late gadolinium enhancement and extracellular volume mapping enabling quantification of myocardial amyloid infiltration. Echocardiography remains the first-line imaging modality in ATTR-CM and often provides the initial suspicion of disease. The classic findings reflect the underlying infiltrative process. We typically see increased left ventricular wall thickness, often greater than 12 millimeters, in the absence of a clear alternative cause, such as hypertension. This is usually accompanied by biventricular involvement, which helps to distinguish it from more isolated forms of hypertrophy. Diastolic dysfunction is almost universal and reflects the increased myocardial stiffness caused by the amyloid infiltration. In terms of systolic function, while ejection fraction may be preserved early on, global longitudinal strain is reduced, with a characteristic pattern of apical sparing, where basal and mid segments are disproportionately affected compared to the apex. While these classical features are important to support diagnosis, in the current treatment era, the key question is not just identifying ATTR-CM, but determining which echocardiographic parameters best track disease progression and predict outcomes over time. So, moving beyond diagnosis, these are the key echocardiographic parameters that are most informative for the prognosis and longitudinal monitoring in ATTR-CM, which I'll be talking about in the next few slides. GLS, or global longitudinal strain, is the strongest echocardiographic predictor of mortality in ATTR-CM and remains independently prognostic even after adjustment for clinical variables in treatment. Each 1% worsening in GLS is associated with around 8% increase in mortality risk, and GLS-based staging shows a clear stepwise reduction in survival across categories. Importantly, GLS provides incremental prognostic value beyond NAC biomarker staging. In terms of therapy, the consistent finding across trials and real-world data is that treatments such as tafamidis, patisiran, and vutrisiran attenuate the decline in GLS rather than improve it. GLS detects these treatment effects, whereas LVEF does not, making it a more sensitive marker of response. So the key concept in ATTR-CM is that stabilization of GLS represents meaningful treatment success, and serial strain imaging should be part of routine follow-up. Stroke volume index is a particularly important parameter in ATTR-CM, as it reflects the underlying restrictive physiology integrating systolic function, concentric remodeling, and reduced cavity size. It is independently associated with mortality and adds prognostic value beyond biomarker staging. From a monitoring perspective, relatively small changes are meaningful. A 5 mil reduction in stroke volume or a 5% decline in LVOT-VTI signals disease progression. And importantly, LVOT-VTI change is independently prognostic after adjusting for age, sex, genotype, AF, NYHA class, and NAC stage. Across major trials, a consistent finding is that disease-modifying therapies attenuate the decline in stroke volume. Tafamidis shows the largest effect with around a 7 mil difference compared to placebo over 30 months, with similar but slightly smaller effects seen in vutrisiran and patisiran. Left atrial dysfunction in ATTR-CM reflects dual pathology, raised LV filling pressures and direct amyloid infiltration of the atrial walls. LA strain captures all three basic functions: reservoir, conduit, and contractile function, making it a comprehensive marker of atrial disease burden. There is also an important phenomenon, atrial electromechanical dissociation, where patients in sinus rhythm have absent LA mechanical contraction in spite of a visible P wave on ECG. In a cohort of 906 patients, 22% were found to have AEMD with significantly worse prognosis. Reduced left atrial strain is associated with a marked increase in mortality risk, with lower reservoir and peak strain values identifying higher risk patients. It also has important clinical implications beyond survival, with impaired reservoir strain linked to thrombotic events, even in patients who are otherwise in sinus rhythm. At the more severe end of the spectrum, markedly reduced contractile strain identifies a particularly high-risk group. Available studies suggest that LA reservoir strain tends to remain stable on therapy rather than showing clear improvement. Importantly, when compared to natural history, tafamidis appears to preserve LA function with significantly less decline over time. Right ventricular involvement represents a later stage of disease and reflects both direct amyloid infiltration and the downstream effects of elevated left side filling pressures. While TAPSE is statistically significant across all ATTR patients, it is angle dependent, load dependent, and only reflects basal longitudinal excursion. RV-free wall strain is independently associated with mortality, with impaired values identifying a significantly higher risk group. In particular, a threshold around 16% clearly separates patients with substantially worse short and medium term survival and adds prognostic value beyond conventional measures such as ejection fraction. It remains to be said, however, that there is no evidence with regards to longitudinal change with very limited treatment data, and therefore this measure remains exploratory at this stage. Bone scintigraphy has become central to the non-invasive diagnosis of ATTR-CM. Using perigeny grading, grade 2 or 3 myocardial uptake is highly specific for ATTR-CM in the appropriate clinical context. While the sensitivity is very high, it's important to note that specificity is low when considering any degree of uptake. The key caveat is that a monoclonal gammopathy must always be excluded, as AL amyloidosis can also demonstrate cardiac uptake and would lead to misdiagnosis if not considered. PET imaging in ATTR-CM is best viewed as an emerging and largely exploratory modality at this stage. The theoretical advantage is that it allows for direct quantification of amyloid burden with parameters such as SUV and retention index, potentially being able to detect disease earlier than conventional imaging. The theoretical advantage is that it allows direct quantification of amyloid burden with parameters such as SUV and retention index, potentially enabling detection of disease earlier than conventional imaging. There is encouraging early evidence showing correlations with CMR, biomarkers, and even outcomes, with PET potentially identifying amyloid in cases where scintigraphy is negative. In terms of treatment monitoring, small studies suggest that tracer signal may change with therapy, and more advanced parametric techniques appear sensitive to early treatment effects. However, it's important to emphasize that the evidence is limited. Studies are small, tracers are not standardized, and none are approved for cardiac amyloidosis. So at present, PET remains a research tool, but one with significant potential for the future. Cardiac MRI provides direct tissue characterization in ATTR-CM. Late gadolinium enhancement typically shows a subendocardial to transmural pattern, often involving both ventricles. Native T1 values are elevated, reflecting diffuse myocardial involvement. Most importantly, extracellular volume provides a quantitative measure of amyloid burden and is strongly associated with both disease severity and mortality. In a cohort of around 1,600 patients, a study at the NAC demonstrated a clear stepwise decline in survival with increasing ECV, reflecting greater myocardial amyloid infiltration. Serial imaging studies have shown that changes over time are also clinically meaningful. In particular, an increase of ECV of 5% or more over 1 year is independently associated with mortality, even after adjusting for biomarker progression. So ECV not only reflects the disease severity at a single time point, but also provides a valuable tool for tracking disease progression over time. Bringing this together, an integrated imaging approach is key in ATTR-CM. At baseline, echocardiography with strain provides functional assessment. CMR allows for quantification of amyloid burden where available, and bone scintigraphy supports non-invasive diagnosis. For follow-up, echocardiography remains the cornerstone, allowing serial assessment of parameters such as GLS, left atrial strain, right ventricular function, and stroke volume. More advanced monitoring with CMR can be performed less frequently to track changes in amyloid burden over time. In summary, each parameter reflects a different aspect of the disease, and together they provide a complete picture. I will hand over to Olivier now, who will lead the next two chapters, starting with the autonomic signal in ATTR-CM.
Hello everyone, I'm Olivier Lerez. I'm cardiologist and nuclear physician at the University Hospital of Toulouse in France, and I'm working in the field of cardiac imaging, particularly exploring the myocardium and the cardiomyopathy, and so I'm really interested and working in the field of cardiac amyloidosis. Here I would like to treat the dedicated topic of the autonomic signal in patients with ATTR. So we are all knowing the pathophysiology of the TTR. I mean the fibrils formation through the production of the transthyretin from the liver, to the destabilization of the transthyretin leading to monomer, and monomer accumulation within fibrils leading to organ involvement, and particularly cardiac involvement and nerve involvement. So we are all focusing on the heart and also on polyneuropathy, which are going to lead to the most quantitative scientific evidence that we get in the field of ATTR. But in practice, if we are considering the patient point of view, and if we are considering qualitative research with less maybe patient, but more I will say more details in the field of the amyloid burden for the patient, we will see that the phenotype it's probably more heterogeneous, and there is a lot of different symptoms leading to a lot of burden for the patient, which are not only focusing on the nerve and not only focusing on the quality of life limitation because of the heart failure, but also a lot of other involvement. And most of them are linked to the dysautonomic dysfunction because of the autonomic system involvement because of the ATTR. And so I think it's important to remember the systemic pathophysiology of the disease and the systemic involvement of the ATTR within the whole body, leading to a lot of manifestation, which can be the musculoskeletal manifestation of the ATTR, obviously the heart involvement, the nerve involvement, but also, and we are going to focus on that, the autonomic involvement leading to dysautonomia and also gastrointestinal symptoms. So in practice, and I think that's the way we are going to go, it's to be able to propose a more patient-centered approach. And here you can see one of the examples of the centered approach of the patient in the field of heart failure. And obviously, patient wants to decrease the mortality of the disease linked to the disease. Obviously, we want to decrease the hospitalization because of cardiovascular events of heart failure. But there is also a part of side effect of the treatment, complication of the disease, but also symptoms associated with the disease, and obviously to be able to keep the autonomy of the patient. So a lot of different manifestation, not manifestation, but consideration by the patient for the management of the disease. That's why I would like to focus here on the autonomic signal. The autonomic signal, it's a kind of expression to consider the dysautonomia, which is particularly prevalent in the field of ATTR. Dysautonomia and the autonomic system is linked to two systems, the balance between the parasympathetic system and the sympathetic system. And that can lead to a lot of cardiovascular manifestation, including hypotension, but also gastrointestinal symptoms, and we will come back on it, but also genitourinary manifestation. And so we are all considering most of the time that patients with variant have more polyneuropathy, and probably linked to this nerve involvement, more dysautonomic dysfunction. But in practice, if we are looking at the clinical data and scientific evidence in this field, patients with wild-type ATTR have also a lot of dysautonomic manifestation. They can have a lot of polyneuropathy, most of the time with less clinical manifestation, but if you are quantifying the nerve involvement in this patient is not so rare. And you can see that there is also a lot of autonomic dysfunction in this patient, gastrointestinal symptoms, leading to the loss of weight. So if we are looking at the prevalence of this manifestation, they are not so rare and they are quite frequent. The point is always to know which tool is used to quantify this manifestation, but you can see here that according to the different point to quantify the dysautonomic dysfunction, you can see that the prevalence is not so rare, and so the phenotype of this manifestation can be really heterogeneous. And that's matter because that's impact the prognosis of the patient, because you can see here, according to the heart rate response to atropine or MIBG scintigraphy, which allow the quantification of the autonomic nerve within the heart, you can see that patients with autonomic dysfunction, according to these tools, have a worse prognosis than patients without autonomic dysfunction. That means that autonomic dysfunction impact the prognosis of this patient and matters in the management of this patient. So the main common manifestation is probably the orthostatic hypotension. And so there is different manifestation of the orthostatic hypotension. And we are all considering that this is only one expression of the dysautonomic dysfunction. But you can see here that there is different manifestation depending on the heart rate response and also the blood pressure response, obviously, and the time before the stand-up and the manifestation of the the drop down of the arterial pressure. And that's only the main quantification of this manifestation. But at the end, there is a clinical manifestation of the hypotension, which are the falls, the loss of autonomia, but also asthenia. In a lot of cases, the limitation to introduce cardiovascular treatment, and also an increase of the frailty of the patient. In practice, there is a questionnaire allowing to quantify this dysautonomic dysfunction. The goal here is to be able to standardize the signal and the autonomic signal, particularly using the COMPASE 31, which is a questionnaire with 31 items, 6 domains, allowing to quantify all the different clinical manifestations of the dysautonomia. And so we should use this survey in daily practice to be able to be more efficient in the quantification of the autonomic manifestation and dysautonomia of our patients. And so in practice, to monitor this manifestation, to each visit, we should be able to quantify orthostatic symptoms, blood pressure, lying down and after standing after 1, 3, and 5 minutes, to quantify the falls, the potential effect on the gastrointestinal symptoms, I mean diarrhea, constipation, and the consequence in terms of weight, urinary issues, and to take care of the medication associated with the increase of the symptoms. In practice, there is a lot of tools to quantify that, and I'm not going to detail all these tools. We already talked about the heart rate response to atropine, and there is also MIBG scintigraphy allowing to quantify the nervous system within the heart, but there is also different tools like heart rate variability, blood pressure after standing up 1, 2, 3, and 5 minutes, and different tools. The most important is to think about that and to use the right tool to quantify the symptoms associated with the manifestation of the patient. In practice, once we are able to quantify this manifestation, is there any solution for that? So we have now treatment allowing to decrease the impact of the dysautonomic dysfunction. Here, in this field, in the field of ATTR, the main scientific evidence are going with the silencer, and I would like to show you a few data about a silencer here. First of all, the data about patisiran and data extract for the Apollo B trial showing that patisiran is able to decrease the dysautonomic dysfunction associated with ATTR in patients with variants. Here in patients with polyneuropathy, and you can see that you are going to decrease the polyneuropathy obviously, but also the gastrointestinal manifestation associated with that. And you can see the decrease of the wall manifestation quantified by the COMPASE 31. This is the same if you are considering pooling data of patisiran and vutrisiran, and you can see that you are able to decrease orthostatic hypotension associated with ATTR in these clinical trials. We have also evidence with eplontersen in the neurotransform trial showing that if you are considering polyneuropathy, but obviously here dysautonomic manifestation, and gastrointestinal manifestation associated with this dysautonomic manifestation, you can see that the treatment, the silencer here, the eplontersen, decrease this manifestation. So in practice, autonomic symptoms should be screened, scored, and followed because they are treatable, measurable, and meaningful for the patient. Next, I would like to focus a little bit more on gastrointestinal dysfunction and how to best assess in our daily practice this gastrointestinal manifestation. Hello again. I would like now focus on gastrointestinal symptoms associated with ATTR. And my question is, are we adequately assessing gastrointestinal dysfunction in the daily practice? And you can guess that my response probably is going to be no. And I would like maybe to change your way to assess this manifestation. Because as we already saw in the daily practice, and if we are considering qualitative research in the field of ATTR, we can see that if we are not considering only the polyneuropathy and the heart, there is a lot of different manifestation and heterogeneous phenotype. And within this heterogeneous phenotype, you can see that there is a lot of gastrointestinal dysfunction and manifestation. And that's going to lead to the loss of weight of the patient and to the malnutrition of the patient, which have a big impact on the prognosis and obviously the quality of life. So what are the impact of the impaired enteric nervous system? If we're considering the pathophysiological process of ATTR deposition, there is a lot of deposition obviously within the heart, within the nerve, but also within the autonomic nervous system, and within this autonomic nervous system, within the enteric nervous system. And that's going to lead to a lot of consequence with impaired digestive motility, secretory dysfunction, malabsorption, bacterial overgrowth, malnutrition, and all that are going to impact the prognosis of the patient and obviously the quality of life. Because they are going to lead to a lot of different symptoms which can limit the autonomy of the patient and the quality of life of the patient. And these symptoms can be early satiety, gastroparesis, nausea, vomiting, constipation, alternation of constipation and diarrhea, and consequently loss of weight and decrease of the prognosis at the end. And so if you are looking at the prevalence, if we are looking from the patient side and the patient experience, we can see that the whole gastrointestinal symptoms are quite frequent, reaching almost 2/3 of the patient. And you can see that they are heterogeneous, they are all different. And if we are looking to the time between the beginning of the disease and the time of the manifestation, you can see that that's increased with the time. And so in patient after 10 years of disease manifestation, there is a lot of prevalence of gastrointestinal symptoms in this patient. And so in practice, we should be proactive to find these symptoms because patients are arriving to the visit for cardiac issues or nerve issues, polyneuropathy. They are not going to focus on the gastrointestinal symptoms, but they are part of the disease. And so if we are not asking to the patient, most of the time they are not going to report the symptoms. And there is a lot of different solutions to fight the symptoms. I mean, to fight the consequence of the ATTR. There is treatment for gastroparesia. There is treatment for bacterial overgrowth with antibiotics. There is different treatment to fight constipation, to fight diarrhea. But the main thing is probably to treat the cause and not only the consequence, which is important because that can avoid symptoms, but the goal is to prevent the evolution of the disease and the gastrointestinal symptoms. And so we have now scientific evidence showing that, for example, here I would like to focus on the HELIOS-B data, showing that after randomization, patients with vutrisiran, which is the siRNA, the silencer, allowing to decrease the level of TTR, circulating TTR, and allowing to fight the ATTR process. In patients with vutrisiran, there is a decrease of gastrointestinal manifestation on the overall population, but also on the monotherapy, and also in patients with tafamidis at the baseline. And which is important is to consider that the effects are still present in patients with wild type, and gastrointestinal manifestations are not only in patients with hereditary ATTR, but also in wild type ATTR, and in the whole population, including hereditary patients, but also wild type patients, the vutrisiran allow to decrease the gastrointestinal manifestation associated with the disease. So in practice, I think that gastrointestinal dysfunction is frequent and it's probably under-recognized because we are not focusing to these symptoms when we are seeing the patient. Symptoms results for autonomic dysfunction, but also enteric nervous system involvement. And patients, most of the time, do not report these symptoms, except if we take the time to ask the patient. That symptoms strongly impact the nutrition, leading to frailty and decrease of quality of life. and systemic assessment should be part of the routine assessment of a TTR patient. And TTR-targeted therapy may stabilize or improve gastrointestinal manifestation. That's why we should look at these symptoms in the daily practice. So this is all from me today, and to finalize, I would like to hand it back to Prem Soman.
Well, hello again, and I hope you found those talks helpful, the overview of imaging and the overview of extracardiac manifestations. It's been a delightful experience to moderate this very important program with Awais and Olivier. And so in closing, to sort of recap the important messages from today's talks, the current recommendations for monitoring cardiac amyloidosis does not include imaging parameters. The monitoring parameters evaluate disease progression rather than specifically progressive amyloidosis, and therefore should not at this point be used to make decisions about specific therapy for amyloidosis itself. Imaging provides unique insights into disease pathology, and CMR and PET may be useful specifically for detecting progressive amyloidosis or a regression in amyloid burden. And importantly, amyloidosis is a multi-system disease. Extracardiac manifestations such as autonomic neuropathy and gastrointestinal manifestations add importantly to the patient's morbidity and influence their quality of life, and they should be sought out as specific therapeutic targets. Thank you very much for your attention, and thank you to Dr. Sheikh and Dr. Lorais for their important contributions. Thank you very much.
This program was presented by Medscape Education Global.